Hello, welcome back. We're working on the heart examination for visceral diagnosis, week 6. So if you want to come over here, you're going to start off with your patient in a supine position. And you would have them disrobe down to the waist, but if the guys are okay with taking off their shirts, you can go ahead and have them do that. So that's what we did with Jeff here. And I'm going to go ahead and point out that typically it's a little easier to find the APETEME area, but you'll have to make sure that you really feel around because Jeff is an example where it's not as easy to find it right away, or it's lower than what you think it is. So starting down at the notch, most people would probably think that it would be located here initially, but it actually starts down lower. So make sure you really if you need to, count down the intercostal spaces rather than feeling down this way because you don't always feel that decline. So in such case, the decline is not really felt as well, but you can certainly tell that this is the first intercostal space, this is the second. So starting the second intercostal space on the right side of the patient's body, you're not allowed putting the letters down during the examination, but you can do this for practice, so I have it down here so it's easier to tell. So A for aorta on the right side, second intercostal space, P for pulmonic in the second intercostal space on the left side. Following that in the third is the Erb's point, the tricuspid, and then down in the fifth, right mid-clavicular area, typically right below the nipple, would be the mitral area, also known as the point of maximal intensity. And then also the epigastric area, I just labeled that just so you know that's just inferior to the xiphoid process. Don't really need to mark that off or anything. None of these you need to mark off. So you're going to start off with inspection with the heart. Starting off by inspecting, checking for dyspnea, checking for pulsations at the APETME areas. Checking for apical impulse, like I said earlier, is what you look here in the fifth intercostal space at the mitral area, because that's the point of maximal intensity. And you're also inspecting for precordial heaves, just making sure you're not seeing any rapid pulsations going on. You should just see normal rhythmic breathing, not seeing much going on. You also check your patient for cyanosis, checking to make sure their lips aren't blue, that their ears aren't blue, checking their finger. Can I see your fingers, please? Also looking at the fingers to make sure their fingers aren't blue. You can go ahead and place them down. And then you also come down to the bottom, and once again checking for pitting edema, like you did in the other examinations. You do this right in between the ulna and the ankle right here. Same concept, you would press down with your thumb, release. Same thing on the opposite side, press down, release, making sure that it's going to return to its normal color and that there's no actual imprint left in the skin. And in such case, Jeff has no problem there, so he's good to go. And remember always to stay on the right side of the patient. You're not walking over to the opposite side at any point. You stay on the right side of the patient while you're doing this. So, okay, we finished inspection. We're now moving on to palpation. Checking for APETME, the areas that we labeled. Checking with our finger pads. So we're using our finger pads to feel here. And you're not moving it. You're just holding there for 3 to 5 seconds. I'm feeling for the pulsations. Checking over in pulmonic. Move down one intercostal space at Erb's point now. Moving down one more intercostal space, and notice it's obviously, we all know it's easier to do it on the guys. And if you had a female in this area, you would have the tube top on. And Dr. Strong had actually talked about putting a clip in the middle, so that way it's easier to place your finger pads right here. And you would have the female patient, she could tuck her thumbs into her, underneath her armpits right here, and pull her breasts up. Pull them down or pull them out this way, so you could actually, she'll have her fingers protecting her breast tissue, and you could try to feel off to the side as much as possible, which obviously it's not always going to be so easy. So in such case, so I'd be feeling here for the tricuspid area, and then moving down to the mitral area, feeling for pulsations there. And then also while you're in the mitral area, you're checking for apical impulse to include location and amplitude. You have to make sure you say this once you arrive to this point. Also coming down the epigastric area. And now this one, you make sure you put your hand flat down, making sure the tips of your fingers are pointing toward his left shoulder right here. So I'm holding it down here with my hand together, my fingers pointing in the left, toward the left shoulder right there. And I'm not sure if you have to actually say this, but if you feel the pulsations going from superior to inferior, that may indicate right ventricular enlargement or inferior to superior abdominal aortic aneurysm. All right, we're moving on to check for thrills. We check thrills with the ball of our hand. So from here, I would hold, you make sure you really exaggerate. You're feeling with the ball of your hand right here, feeling in each of the areas, all of the areas except for the epigastric. So we'd repeat again. Feeling for thrills, which we know that's just really strong vibrations, turbulent blood flow. So we check in all the areas. And remember again, when you're feeling on a female, you would have them again. You can bring your thumb, tuck your thumbs into underneath your armpits, have them pull the breast tissue down so I can feel here in palmatic. Can you go ahead and separate the breast tissue? I'd be trying to place it right on top of their hands so you don't have to invade their space, their area right there. Pulling it up, please, and you come down to the mitral area, hold it there. Good. Okay, so we're moving on to percussion now, the fun part. We're going to identify the location and the size of the heart. Identify the location and the size of the heart. Do we have to percuss right down this area? I'm trying to remember how to do this one right here.
You're starting at the third.
All right,
Third,
so
fourth, and fifth.
What we're going to do, so you just state that you're checking for location and size of the heart. And then you go on to percuss the lateral to medial side. Of the male, you do three areas at the third, fourth, and fifth intercostal spaces. And then for the female, you're only doing 2 areas, only at the third and fifth, obviously because of breast tissue causing it to be harder to check for the tricuspid area. So we'll start off, since he's a male, we'll do the 3 areas there. So what you would do is we'll start over from the lateral side. We're doing 4th, 5th, so right here. So 4th intercostal space is epigastric, 5th being the tricuspid, and the 5th one, I might have just said that wrong, but the 5th one is mitral.
Erb's point, not epigastric.
Sorry, not epigastric, Erb's point. I said that wrong. You know what I mean, though. Okay, so you'll come over, not in the axillary region. You don't need to go that far over. So make sure you're feeling to make sure in the intercostal space, even though you have it marked right now, you're not allowed marking it in the exam. So make sure you feel for that. You work your way down, feel for the second, come down to the 3rd space right here, and move your finger over. So from here, can I place this right here? You're going to make sure you really, for females, make sure you clip your nails so you don't stab your patient with your nails. You're really going to press down with that finger right there. Now, I didn't feel the difference till right there, but we'll do that again just to make sure. Is that where I find it's kind of sound different?
Right there.
Right about here. So we would go ahead and make a slash, a horizontal slash right here. So coming over here in the 4th intercostal space right here.
You make it like this.
Does that have to be
Vertical.
vertical right there? Sorry. We make a vertical. And in such case, you would have to bring your finger down and make a vertical space right there. So I messed that up. Sorry. So down in the 4th intercostal space. And I'm doing it for the change and to going to dullness right here. It's not looking so bad so far. So then we come over on the 5th intercostal space, same thing again, checking your hearing for resonance and then going to dull. And whenever you hear the dullness is where you're making the mark. Sorry. All right, it really stopped right here. All right, so we have the 3 spots right there going from resonance to dullness right there. Sorry, it might not be as loud as what we have in Mosby's videos, but you know what I'm talking about in this area. So we have those areas marked right there. Now we're moving on to percussing the right sternal border. I think, what exactly is this for? Indicating the superior border of the liver right there. So we're moving down to the 6th intercostal space now. And we're going to percuss across that area as well. And now if we were doing this on the female with what I just did, you would be sure to have the female bring the breast tissue down while you're doing the 4th intercostal space, and to bring the breast tissue up, or sorry, 3rd intercostal space, and then bring the breast tissue up when you're working on the 5th intercostal space. So remember to tell them to move the breast tissue, which it'll be a little more obvious when you're doing it. Okay, so now we're feeling for going into the 6th intercostal space. So I know that this is my 5th one. I can go ahead and just move down one more.
And do it on the right side.
And we'll do it on the right side. So let's see. We know this is the 2nd,
You start up and
3rd, 4th, 5th, and then 6th. So it's typically in the 6th area, but what you would actually do is you're going to start on the right side of the sternal border, assuming that it's going to end about the 6th intercostal space, but we're going to act like we don't know this right now. A little harder to call. We'll start over again on him. Getting a little dull right there.
You want your fingers to be like this, coming across this way.
That's the easiest to feel, to be quite honest.
You want your fingers to be like this. You don't want them to be like this. You got to get in the intercostal space.
Yeah. And now we're presuming, oh, it's pretty dull right here. So this is where it's going to be. You would make a horizontal line at this point. You go ahead and make a horizontal line there, indicating that's where the liver is going to be. All right, moving on. So you make only one horizontal line right there, noting the location of the liver, which is going to sound dull at that point. All right, moving on to auscultation. So just a reminder, if you look inside your manual for this, you can move on to page 46, and it'll let you know how you can make this process a little bit faster by doubling up some of the examinations that you have to do. So move on to page 46 and read over this because it'll make it flow a lot nicer. So we're going on to auscultation of the heart. I'm going to start over at the mitral area. I'm using the diaphragm to auscultate for S1 while palpating the carotid pulse. Alright, diaphragm. So you're going to go ahead and feel for the carotid pulse right here. And we're going to check in the, in the mitral area, so we already know where that's at, right beneath here in the 5th intercostal space. Placing the diaphragm right there and feeling for carotid pulse. And then what you're checking here is to make sure that you can hear and you're feeling the pulse at the same exact time. Synchronous. Good. Okay. Then while you're doing that, you're going to have the patient actually take a deep breath in, exhale, and then hold. So Jeff, can you take a deep breath in for me, please? And then exhale, and as you exhale, hold it out right there, and then I'm going to feel that.
You have 2 minutes left.
All right. So, okay, we're moving on. Now we're moving down to Erb's point, checking for rate and rhythm. Rate and rhythm at beats less than 100 beats per minute. Systole, it should be shorter than diastole, and obviously diastole should be longer. So here at Erb's point right there, we're using the diaphragm to auscultate APE-TME for general cardiac sounds. So you're checking in all areas, 3 to 5 seconds, moving down in all the general areas. Then once you get down to the mitral area, you're using the diaphragm again to listen for S1, and S1 is the best place. It's the best heard at the apex of the heart, which is here at the mitral area, also known as the point of maximal intensity. So you're staying there and you're now listening during systole, stating that you actually state that you will be listening to S1 to see if it is either accentuated or diminished, and you'll be listening for splitting of S1. And then you state that you are then listening for systole for murmurs or for other abnormal heart sounds. You go up to the pulmonic area. You continue to use the diaphragm listening for S2. State that S2 is best heard at this point, and then you stay at this point and you say that you're listening for diastole, stating that you're listening to see if S2 is accentuated or diminished, and that you'll be listening for the splitting of S2. Then you move on and you have the patient assume a lateral recumbent position as we're listening for a murmur. So, Jeff, can I have you at a 45-degree angle? First, before you have him at a 45-degree angle, you would place the bell of the stethoscope, so make sure you turn it over. The bell of the stethoscope at the mitral area. Can you go ahead and lean yourself over at a 45-degree angle right here? And you would hold them there in this position. Have them take a deep breath and hold, please. And you're listening for mitral murmurs right here at a 45-degree angle, holding it here at the mitral space. Go ahead and lay it back down. Thank you very much. And then you have the patient assume a seated position. So you got to sit up and have a seated position. And then you place the diaphragm at the aortic area or at Erb's point. So wherever you prefer, making sure you have the diaphragm placed here at the aortic or Erb's point. Wherever I'm going to go ahead and place mine at the Erb's point. And you have the patient breathe in and let out with a slow sigh as they lean forward. So as you're leaning forward, slow sigh, release it. About